I think Professor Ibi is keeping us in suspense. Um, and it seems to have cut, but I'm sure that he'll be here in a second. So please continue to watch this space. And as ever, please feel free to write in the chat for any of your questions. And also at the end, I'll also be fielding questions. So some people really love to put their hand up and engage, which we really love as well, and to hear your experiences. So please don't be shy. This session is for you. So in the chat or hands up at the end, and we'll all learn together. So please bear with us. I'm sure Prof. Ibi will be back with us shortly. Just go on, I'm sure he'll be here. I'm currently in Ghana, so I was expecting this to happen to me. So I feel quite, yeah, the Ghanaian Wi-Fi is not letting me down. So I'll be very happy about that. But do bear with us. I'm sure he'll be here shortly. For those of you that have just come on, welcome. We have Prof. Ibi, who is going to be talking to us about looking after our kidneys. We just seem to have had a technical hitch where we've lost him, but I'm sure that he'll be on shortly. So please bear with us, but don't leave, he'll be on. I believe we're making contact with him just to see if we can help. So.
Yes, we are.
Lovely. Unfortunately, I specialize in, well, not unfortunately, but I specialize in sexual health and HIV. And so I don't think I'm the best person to intervene at the moment. I did learn my renal medicine, but that was quite a while ago. So I will be doing you a disservice if I jumped in. So bear with us. Whilst we're waiting, I'm just going to do two things. First of all, reminding you of all the organizations that are involved today to make today happen. And then it may be that one of my colleagues may come, and we often have announcements that happen at the end and everyone rushes off and you don't often get a chance to hear all those announcements, which there are some great things that happen in the week. So I'm perhaps going to ask one of my colleagues to do the announcements if it's appropriate. But as I said earlier, just reminding those of you that have come on, this is the CAHN Health Hour, and it's a collaboration of fantastic organizations that have come together, recognizing that us within Black communities, that there are certain conditions that are more prevalent within our communities. The way that we experience health and we access health may be different. And the key thing is that how do we support one another to make sure that we are educated, we know how to access care so we can get the best outcomes possible. And these organizations which make up CAHN are RAFA, Croydon BME Forum, Enfield Caribbean Association, BHI, the Redeemed Church of God, CAHN, all these organizations are working together in the background to make this happen. And I always say that it's unique when you have so many organizations coming together to do this, but it's beautiful because there are clear inequalities and we need to respond to them together. So thank you again for you all being here. We don't take Saturday mornings lightly. I believe Prof. Ibi is on his, he's trying to reconnect. For those of you that have just come on, welcome. Our speaker got disconnected, so we're just waiting for him. Appreciating your patience. I know people are scrambling in the background. Thank you. We've had a great suggestion about us making sure that Prof. Ibi knows. I believe he does know, but thank you for that, because that has happened to me where I was speaking and I wasn't aware that I'd been disconnected, and I spoke for a good hour and my phone wasn't with me. So it made it all worse. So I believe he does know, but thank you for the suggestion, and thank you for the patience, everyone. I think Prof. Ibi is back. Don't want to get too excited, but I think he is.
Dr. Vanessa, as you suggested, I think one of our colleagues can take the announcements?
Yeah, that would be great, because I can see, I think Dr. Ibi is trying and it keeps coming out. So we're just going to hand over to one of our colleagues to do the announcements. As I said earlier, often we do these at the end, but they get lost, and there's some really good information. So please bear with us, stay on, listen to the announcements, and we're hoping that we can get on with the presentation again. But thank you so much. So many of you on today, which is fantastic. So please continue to bear with us. I'll hand over.
Okay, so we'll hand over to Percy for the announcements. Thank you.
All right, thank you so much. Thank you so much, Dr. Vanessa. Yeah, just a few, upcoming announcements in terms of what we've got coming on. So next week, it will be focused on spirituality and mental health. I would have Dr. Joe with us. He's a familiar face in the house, really. He has been on here quite a number of times, and he's a faith leader as well. So nobody better, really, in terms of doing justice to that topic. So we look forward to that. Just make sure you're on as well. I'm sure we'll have all the technical issues sorted out by then, and you won't have any issues with it. So Dr. Joe on Saturday. Then within the week, we'll be having the Healthy Hearts as usual. So that will be from 6 to 7:30. Typical format of having a talk on nutrition and health and diet, which will be followed by 30 minutes for physical activity, really. So please do endeavor to join with that on Tuesday evening. Next slide, please. Yeah, then an upcoming event, really. So this is on the 20th. So CAHN, alongside some of our partners, we'll be looking at hosting an event with the Chief Constable in Manchester. It will be at the church venue in Clayton. So please do endeavor to register for that. I'm sure my colleagues will put the details in the chat box. So please do endeavor to try and attend if you're in Manchester. It's next 2 weeks, Monday. So please do endeavor to attend. And I'm sure the next thing we've got on there is just giving appreciation, really, in terms of our partners. But before I forget,
I wish I could replicate her 1,000 times.
Oh, I think so. Yeah, just in terms of the services that are also available at CAHN. So we've got the CAHN.
I think you can carry on, Percy.
Can you hear me?
We can hear you.
All right, that's perfect. Oh, sorry about that. Yeah, so in terms of the services that we didn't really, there are a couple of services that are there and they are freely available to everyone. You can access them, really. So we've got the counseling service, we've got the advocacy service as well. We've got also our helpline, and there is another service that is in the works now, so a green and arts wellbeing service. So please do look out for them. In terms of assessing it, please, the numbers are on there. You can always give us a call and order. Then if you want to be signposted or other things, we could as well do that. Just about providing support, really, to members of the community. So please feel free to reach out to the numbers and to assess the services based on needs, really. Then just to give credit to our various partners, I know Dr. Vanessa has gone through them, really. So we've got CAHN as well. So CAHN, the organization, we've got Black Health Initiative, we've got RAFA, we've got Croydon BME, we've got the Enfit Caribbean Association, we've got the Redeemed Christian Church of God as well, and then we've got BHI as well. So these are just organizations that have come together, and they're doing great work on their part, really, when it comes to around health inequalities, really. It's just about how we create that holistic support for our community members. They've come together to put this program for us, really, just to build our health literacy, our understanding of these conditions, really, that affect us, just like the one Dr. Ibi is trying to take us through today. We know he has had issues with his connection, but hopefully he'll be here to take us through most of that real soon. So thank you very much.
Thank you so much, Percy. And first of all, thank you all for your patience and endeavoring. And thank you for Auntie Elizabeth, who has also been trying to ensure that Prof. Ibi comes back. And I believe that Prof. Ibi is back.
He is back.
He is. So Prof. Ibi, I've told everyone that I have no substitute at all in this area, and we've been looking forward to hearing from you. So if you are ready, then I will hand over back to you.
I don't know what happened.
Well, no, I'm just glad I can hear your voice, because at that point I was starting to get very nervous.
I don't know what happened. I've been talking for 15 minutes.
Oh no.
So,
well,
we're
very excited to have you back. So I'm going to stop talking and hand over again to you. But just to let you know, we only got to overview.
Sorry?
We only got to your second slide, overview.
Okay, all right.
Yeah,
okay,
thank you.
Okay, no problem. Because somebody was telling me that they can't hear me at all. So let me, just 1 second. Let me just get back on track. Okay, let me share my slide now. Can you see my slides? Yeah, okay.
We can. Perfect. And so, yeah, lovely. Thank you so much.
Okay, so was it where we were that I lost you guys?
We lost you at the second slide. We only got to overview.
Okay, this one.
The one before, in fact.
This one.
Yes.
Okay, I'm very sorry about this, everybody. I don't know what happened. I got disconnected. I was just talking to myself on the, and I did see myself again. I was just talking. I said, well, maybe it's because the old stars just didn't want to see my face. So I just thought that. so I'm very sorry. So we still have some time. We can just stretch it to 12:30. I hope you don't mind, Vanessa. So you don't mind if we stretch it to 12:30, because we've lost about 20 minutes now. Yeah,
I think we'll let you continue, and then with questions we can continue, and whoever can stay, and whoever needs to go can go. That's great. So please continue.
Okay,
thank you.
Okay, so the outline for this presentation will be, I'll just introduce the topic, and then I'll look at background of kidneys in health, and what is chronic kidney disease, and the risk factors, and management and prevention. Now, there are 3 key areas that I want to emphasize, which is kidneys in health, and then talk about the risk factors, and then prevention. So first of all, as an introduction, I want to say that the kidneys are 2 bean-shaped organs, and so they are about the size of your fist. And so basically, if you just fist up, you will just realize that this is the size of your kidney. They're small organs, but they're powerful chemical factories. And so they ensure that your body chemicals are balanced, and they get rid of toxins and unwanted chemicals. And so this is why we are giving this talk, for you to understand what the kidney does, and then to look after your kidneys. And so just to set the scene, I just want to make you aware that the kidneys are 2, like I said, kidneys are 2 bean-shaped organs, and they're mainly towards to your back, and medically we'll say it's posterior. So if you look at my cursor, you can see that you produce urine, it goes into the bladder, which is a tank, and when you're ready to void, it now goes through your urethra. So what does then the kidney does? If I go back to this slide, just have that mental picture, and then you'll be able to understand. So as we go to the next slide, you see that it cleans your blood of waste products and extra water, and then it helps control blood pressure. So be aware that the heart is not the seat of blood pressure control. It's the kidneys are the seat of blood pressure control. And it also ensures healthy bone, and healthy and strong bones, and also helps you make red blood cells through erythropoietin. It also helps with balance of your minerals in your body, like sodium, phosphorus, and calcium and potassium. So you can see that though it is a tiny piece of organ, but it does marvelous things in your body. So just as an extension, you can see that the kidneys have what we call the calyces. If you slice the kidney into two, I'm not saying it's the kidneys that we go to buy in the in the market, but if you slice the kidneys, you see that these are the filtration components of the kidneys. And so if you interpose this to this, you can see that this Wrigley organ, and these are called the nephrons, the filtration units of the kidneys. And these are what is responsible for filtering your blood. So when blood enters here, it filters it, it goes through and gets back through the vein. And so there are 1 million of each in each kidney. And it's called I always tell patients that we'll call it the filtration unit. And this is what gets damaged when you have kidney disease. So in the next slide, I'll just show a bit more of the cartoon. So filtered blood gets into the kidneys, it gets filtered here, and then you can see the filtration units I showed to you, which we call nephrons. And then after the blood is filtered, the blood goes back through the vein, and then it now comes out as urine, and then it's stored in the bladder, which serves as a tank. And so you can see that this tiny piece of organ here is so important, called the nephron. So this is just a summary of what I've just been saying in terms of the kidneys in health. So it ensures that there's not too much or too little water, and also there's also ensure that your blood pressure control is okay, and it gets rid of waste products, and it ensures bone health and acid-base balance, which is make sure that your body is not too alkaline or too acidic. And because it's responsible for the maintenance of electrolytes, potassium, sodium, and calcium, which is critical for the health of your heart. And it also ensures that you're not anemic, and it releases erythropoietin to ensure that the bone marrow produces blood cells. So you can see that when kidney patients are sick, when the kidneys pack up and with kidney patients, they are very sick because the kidneys does a lot of stuff. So that brings us to the point. So since I've laid the scene now for what kidneys are in health, you'll be able to understand now what chronic kidney disease is. So chronic kidney disease means lasting damage to the kidneys. The kidneys, unfortunately, do not have the capacity to regenerate. And so when your kidney nephrons die, what happens is that it's now replaced by scars. And so that's as your kidney disease progresses, more scars are laid down. And so eventually you end up with end-stage renal disease. So I can't say it, I can't emphasize it enough that we need to be aware on how to look after our kidneys. So what does this mean? It means damage to the kidneys, hence we can't filter the blood the way we should, and the other functions that are supposed to take place in the kidneys. And so it is a progressive loss of kidney function, and sometimes occurs for many years, and sometimes it remains static. And so in total, in summary, what will define chronic kidney disease is when you have abnormalities of kidney function or structure for more than 3 months. So just be aware of that. So if we just kind of fast forward to look at why are we talking about this? We're talking about this because kidney problems worldwide is getting to an epidemic level now. So worldwide, we have more than 50 million individuals with progressive CKD. And out of these people, 1 million people are treated with renal replacement therapy. That means dialysis and transplantation. And 85% are in developed world. So in the developing world, we cannot afford it. And so people just die of kidney disease. And the WHO statistics does show that CKD is the ranking of the 12th on this list of major causes of death. And what's interesting is that cardiovascular disease which is an integral part of chronic kidney disease, is the leading cause of death in patients with chronic kidney disease. I'll show you a bit more of that in subsequent slides. So where are we here in the UK? Around 3 million people in the UK have chronic kidney disease. And number two is that uncontrolled diabetes and high blood pressure are the biggest causes of chronic kidney disease. And that is something that most people are aware. And right now, around 63,000 people in the UK are treated for kidney failure. And it is when kidney function is less than 15% that patients are put on dialysis, more specifically when it's down to about 8% a year in the UK. So something that I want to emphasize more is that Black and Asian and minority ethnic groups are 5 times more likely to develop chronic kidney disease than other groups. So every day, 20 people in the UK will develop kidney failure of some sorts. So I'll just put that kidney disease because kidney failure is when we have end-stage renal disease, patients on dialysis or kidney transplant. So that is the epidemiology, which is the seriousness of the problem worldwide and within our country and within the country and in the UK. A similar pattern is seen in other parts of the world. So I decided to put this slide to say that the dialysis and transplant is an expensive component of kidney care that we can see as doctors and even everybody. But there is this area that people are ignoring, are those that are at risk. And so that's why I put this iceberg. I got this from one of my late professors. If you look at it, the iceberg is there, the tip of the iceberg was saying that, but lots of stuff is under it. And that is what is happening to those at risk. And I'll show you a bit more of that in subsequent slides. So having said that, so what are now the causes of chronic kidney disease? And you can see 42% is diabetes. These are data, our own local data. And even if you look at the WHO data, it's very similar. 28% are high blood pressure. And if you look at it, glomerular diseases, which is inflammation of the nephron that I showed you before, which is the filtration unit, that's what we call glomerular diseases. So this is what really happens if you look at the data of what is causing kidney disease. But something that is very interesting here is a miscellaneous and unknown category, and I'll throw more light on that. So if you look at chronic kidney disease and the risks, you can see that of what I've been trying to say: high blood pressure, heart disease, obesity, which is overweight, and family history. Age of, if you're 60 and above, you're likely to have, more at risk of having kidney disease. A smoker, diabetes, which is number 1. Now, coming to age, after age 40, we lose 1% of our kidney function yearly. That doesn't mean that we have kidney disease. It's just part of the aging of the kidneys. But having said that, if you compare the age in the UK and America and most of the developed world, and you look at the age match in developing countries, you see that most of the people that end up with end-stage renal disease, which is end-stage kidney disease, is aged between 30 to 40 years old. And that is one of the most productive years. So it's a bit more of a problem in developing countries, especially because there are no resources, or because people are just not aware, and there are a lot of myths around kidney disease. So if you look at this cartoon here, which I've just shown now, if you look at it, diabetes, hypertension, and chronic kidney disease, you can see they're interwoven. And so if you have diabetes, you're likely at some point to have chronic kidney disease. Hypertension, if your hypertension is not well controlled, you're likely to have chronic kidney disease. In sub-Saharan Africa, hypertension leads in terms of causes of chronic kidney disease compared to diabetes. So I just put this because chronic kidney disease and diabetes, that is type 2 diabetes, are disease multipliers for cardiovascular disease. So what do I mean by that? Cardiovascular disease, I mean by heart disease, that's heart attacks and strokes. And so, and other related cardiovascular disease like peripheral vascular disease and all the others. So for patients with both chronic kidney disease and heart disease, kidney disease gets worse and you die sooner. So that's the reality from data. So I just want to mention this because this is something that is very common amongst the Black communities, where people go and buy medicines over the counter. If you look at it, non-steroidal anti-inflammatory agents are the ones that I want to focus on, and herbal remedies and dietary supplements. And there's enough evidence in our research materials that these identifiable causes of chronic kidney disease. So that's something that we should think about when we are going to purchase some of these medications. And if you look at herbs affecting the kidneys, herb-related factors are, there's most times, why are they affecting the kidneys? Because there's incorrect processing, incorrect identification, intrinsic toxicity of the herbs, and there's contamination with heavy metals and all that. So these are some of the things that we should be aware that when we go and purchase herbs, so this is what it leads to kidney injury because of these related factors. So I brought this data. So it's quite interesting. I got this data from WHO, which is global market for herbal supplementation is about $107 billion. But if you look at the slides here, where it is more prevalent, it's in India, sub-Saharan Africa, up to 100 million people live with chronic kidney disease, and Latin America, 60 to 100 million people live with chronic kidney disease. Most of these people use these products, you can see, and so we should be aware that this is something that is very prevalent in our communities. So what happens when the kidney, in chronic kidney disease, you can see the way the kidneys are here, and you can see the way the normal kidney looks like. And this is what the kidney looks like once it's diseased because of all the problems that is faced with diabetes, hypertension, inflammation of the filters, etc. So this is what happens in the kidney when your kidneys are bad. Inside a healthy kidney, the blood is filtered. You make urine. I use this cartoon so that you be aware. Now, all the things that are not supposed to be filtered are now being filtered because inside the damaged kidney, you can see that it's filtered. So just have that picture in your mind that this is what happens when you have a diseased kidney. So what really happens at the different stages of kidney disease? You can see that the healthy kidney there is doing its job. And now the unhealthy kidney, you can see what is happening here. There's problem with filtration and all that. And so this is the way we stage kidney disease according to the affectation of the, in terms of percentages. You can see that stage 1, your kidneys are working more than 90%, but you're leaking some protein in it. And so we classify, you still have kidney disease. So one of the things that we don't want you to come from this stage to this stage. So that is what this talk is all about. So you want your kidneys to be like this, not like this. And so bear that in mind. And so what are the tests that we do for kidney? We do blood tests, we do x-rays, ultrasound, scan when your kidneys have problems. We do kidney biopsy to look at the kidney under the microscope, and we'll do urine tests. Now, I just want to focus on blood tests and urine tests. Simple blood tests will be able to indicate whether you got kidney disease, or even simple urine strip test. Once you find protein in your urine, that's something that should raise alarm bells to say that, do I have kidney disease? If you look at these slides, this is protein that you're looking at. So leakage of protein is one of the first indications that you got kidney disease. So that's one. Then before you go ahead and see a specialist and they want to do imaging of your kidneys, and then maybe if it requires you to do a kidney biopsy so that they can give you the appropriate treatment. So what are the symptoms? Symptoms don't happen until the kidney disease gets advanced. You get nausea and vomiting, tiredness, loss of appetite, your body is all swollen, and your urine becomes bubbly. There's when your urine is very foamy and all that, and then you got itching all over your body, and you become short of breath because your kidneys don't get rid of water. If you look at the first slide I showed, where it showed that the kidney is a major organ that handles water balance in your body, and then you begin to have sleeping difficulties. So these are some of the symptoms when you begin to get progressive kidney disease. You begin to get these symptoms. So just to remind ourselves, so this is the same thing. Stage 1, no problems, but this is where we don't want you to get to, stage 5. So you can see that from what I was describing in the previous slide, and yeah, so it goes with the stages. Stage 1, you have coronary kidney function. Now stage 4, you don't have your kidneys are diseased, and so these are some of the things that you need to look at when we need to remind ourselves, beg your pardon, when we're thinking about looking after our kidneys. I don't want to get to the point where I'll be having all these problems. And look, kidney patients are very sick. I mean, this is a job I've been doing for 25 years. So you don't want to get there. So what do we do as kidney physicians? So once you promptly see your doctor, once you notice protein in your urine and all that, my job is to make sure that we slow the progression of your kidney disease so you don't end up on dialysis or in the process of getting a kidney transplant. So many patients with chronic kidney disease are able to live normal lives without being unduly affected by the condition. That's point 1. So having a kidney disease at stage 2 does not mean that you're going to be on dialysis. What I've found with colleagues in Nigeria, that sometimes people are not told the right things, that when they get kidney function of around 20-25%, they begin to tell them they're going to need dialysis right away. No, that's not true. So some of the things that we need to be able to explain to our patients is that we'll be able to tell them that, look, this is what you need, this is what you need, this is what you need. So everything is planned and all that. But be aware that most people live with kidney disease, chronic kidney disease, if it is well managed. If you manage it well with lifestyle, with your doctor, you'll be able to live. So, but you need to be identified early. And that's why I said the basic tests that you do, especially when you are above age 40. So what do we do in reducing progression of kidney disease? We treat your diabetes and hypertension. We reduce the protein in the urine using medications, and modification of your lifestyle, avoid excess over-the-counter medications, ibuprofen, Motrin, etc., and herbal preparations, and regularly check up with your primary care physician. That is more important. When I make primary care physician is a GP or your doctor who you see regularly, who looks after your blood pressure and diabetes. So you can see this is something that I think you should just bear in mind. So how do we prevent and manage chronic kidney disease? I said there is no cure for kidney disease. I should have put this in bold. So treatment can help relieve the symptoms and stop it getting worse. So we can slow the progression, which means that you can live with your disease probably throughout your life. And then your treatment will depend on the stage of your disease, from what I've shown before. And so the main preventative measures are lifestyle changes and to help you stay as healthy as possible. So what do I mean by that? Lifestyle changes, I've shown you this slide before, but I'll show you a few more slides. So this is what we do in terms of when you have chronic kidney disease, we slow the progression, which I've shown before. And if your kidney disease advanced, we now transit to giving you either dialysis or kidney transplant. But we don't want to get there. That's why we need to focus on these things and be able to prevent chronic kidney disease. And at the beginning, I did say that this is not rocket science. This is very basic. And so we don't need to do very complicated things to stay healthy and look after our kidneys. And so this is just a summary of if you have chronic kidney disease, the routes you go to hemodialysis, peritoneal dialysis, or transplant. And that's not what we want. So I put this, I think this is probably the crux of the matter. Actually, this is the strongest message that this presentation I want to give. So preventing chronic kidney disease, an ounce of prevention is worth a pound of cure. So diet and exercise to maintain a healthy weight. I mean, people think that gaining weight, especially in sub-Saharan Africa, gaining weight is a sign of well-being. No, it's not. You need to watch your weight and exercise regularly. I'm not going to say that you should exercise as if you want to go to a competition, but exercise to remain healthy, smoking cessation, and then controlling diabetes, controlling your blood pressure. I mean, control of blood pressure is something that is so crucial that people just think, they see their doctor, they just take their blood pressure, just off you go. No, when you're going to see a doctor, you should go with your home blood pressure readings to your doctor. Say, is this the target that I'm supposed to have? Today, I'm not going to talk too much about blood pressure control, but for another time, we'll talk about that. Control cholesterol and avoid excess over-the-counter medication. You can see I'm just repeating myself over this, and a regular check with your primary care physician. So I just want to, the next few slides, I just want to bust the myths in hypertension. So hypertension is not a temporary illness that will resolve. So the absence of headaches and dizziness does not mean good blood pressure control. There's no need to experiment with stopping treatment to see if symptoms will reoccur. Do not stop medication because of lack of symptoms. Do not wait for symptoms before you take your medications, please. And then long-term medication is not harmful and does not have any risk of tolerance, dependence, or the drug buildup to harmful effects. Of course, like any other drug, some drugs might, some of antihypertensive medications could have some changes in your, especially in males, it could cause some electrolyte dysfunction. Sometimes it could cause some feel of dizziness, but you can discuss with your doctor to give you the most appropriate medication to help you with that. So alternative medicines are not more effective, but may result in complications and too little, too late. So I needed to say this so that we can link it to all the other slides that I've said, where hypertension is a major cause of chronic kidney disease. So I just wanted to bust the myths, especially in the way we take our medications in regards to high blood pressure. And so that also applies to diabetes. So people take all sorts of agents which are not proven at all to see that will help with their diabetic control, but it doesn't. What it does, it causes more problem for you. And there are loads of good medications now in terms of diabetes treatment, and even more friendly medications in terms of blood pressure treatment. So how do I keep my kidneys healthy then? So these tips can keep your kidneys healthy on track. Regular physical activity, lose weight if you need to, eat less fat, keep your blood pressure, blood sugar, and blood fats under control, stop smoking, keep well hydrated. One of the anchor for this, I mentioned it before, the anchor for this presentation did say that she has water with her because she was coming for this talk. So reduce stress. I mean, that is something that is debatable. Stress is different for different people, but that is not what is even more important. What is more important? Avoid herbal medications. Avoid herbal medication and keep yourself well hydrated. Make sure that your blood pressure, blood sugars, and fats are under control, and your kidneys will be. So this is your kidney health. So there are things that are controlling your kidney health. Your food, exercise habits, compliance to medications if you have hypertension, diabetes, and other diseases that can affect your kidneys, like glomerular diseases, and the healthcare. What's your healthcare provider? What's your healthcare system providing? Environment, genes, and all the genes is linked to diabetes, hypertension, and all that. And then your food. So all these have interplay in your kidney health. So more information about this can be found in this National Kidney Federation for Kidney Disease and UK Kidney Care and Kidney Research UK. So basically, I think I just need to end with this. And so if you have any questions, I'll be able to entertain them. Thank you very much.
Thank you so much, Professor Ibi. And also, thank you, because you did get cut off, and I know what it's like when you're cut off and you have to start again, and it's disorientating. So thank you so much, and thank you so much for everyone that stayed on. And we've got a really a great group of people here today, and I can see as you're finishing, messages are coming on and questions thick and fast. So if you're okay, I'm just going to launch into some of the questions. And also, as I said earlier to everyone, this is for you, excuse me. So if you would like to ask questions and put your hand up, the team here are keeping an eye on everything. So feel free to speak as well. Sometimes it's great to share a lived experience, to ask a question on behalf of a family member. We don't take it lightly when we have professionals here to answer our questions in this way. So Professor Ibi, I'm going to go back to one of the earlier reflections that you made, and a number of people have kind of picked it up. And I think, as ever, when we're talking about health inequalities, people come again to that question, why us? And is it genes? Is it the environment? What are we doing? So you framed that in some of your presentation, but if you could specifically answer that for us, that would be fantastic.
Thank you very much, Vanessa. And I think one thing that we should understand is that if you look at the data of way back 50 years ago, when they even looked at African Americans, where they started a Framingham study, it's been found that hypertension is a disease of Black people. So that is a statement of fact. And now type 2 diabetes has also been found to affect our people. So the question is that it's not because we are Black people, so we're having chronic kidney disease. It's just that the major risk factors that affect chronic kidney disease, that put us at risk of having chronic kidney disease, are diabetes and high blood pressure. And now, just a step further, if you look at glomerular diseases, I did show you slides at the beginning of the filtration unit of the kidney. So if there's inflammation, and most of this inflammation is caused by, some of these are caused by infections, and especially those that have tuned in from Africa and from Nigeria, from my friends and relatives. I mean, this is something that, is common. So infection is on one side, but the two things that are more important is diabetes and hypertension. And unfortunately, like I said, this disease is common among our Black people. And it is it's even people are beginning to be more identified with the disease because there are better diagnoses. People are able to diagnose them and all that. So that's something that it is not as if because, we're Black people, that's why this disease affects us. And also there's a genetic basis. If you look at hypertension, if you look at diabetes, type 2 diabetes.
Thank you so much. And yeah, lots of questions coming through. And, just to say, it's always important to be educated. Being a medic myself, you know this stuff, you've learned it, but when you're taught it again, it's that whole reminder of things. And I think one of the things that is coming across in some of the questions on the chat and personal questions to myself is the whole concept of being at risk and how to intervene early. And there are a number of associations that people weren't very aware of in terms of kidney health. And one of them is hypertension. And how blood pressure is related to kidney dysfunction. And so I know that, again, some of these things were covered, but it's just to re-emphasize about that. And leading on from that, some people are reflecting on that and thinking, I'm on antihypertensive medications, but could any of those cause kidney disease? Because you talked about some medications. So re-emphasizing the link of blood pressure with kidneys, and then hypertensive medications, any ones that we need to be cautious of in kidney disease.
Yeah. Thank you very much, Vanessa. So now, high blood pressure. Let me just make it explain in a very layman's term. High blood pressure. When your blood pressure is high, it's kind of is sharing pressure through your blood vessel. And so what happens is that as that sharing blood pressure, it damages the small, tiny blood vessels in the kidneys. And so over time, once those the cartoon I saw, let me just reshare my. I hope you don't mind if I share my slide again, so that I'll be able to pictorially.
Sure.
Yeah. So I'll just go. Let me just go. Let me just. Okay, so if you look at these blood vessels, you can see them. These are the blood vessels that are damaged by hypertension. And I used to say that hypertension and chronic kidney disease, hypertension can cause chronic kidney disease, and chronic kidney disease patients have hypertension. So we always say that chicken and egg, which one comes first? And so the fact is that if you have chronic kidney disease, because the kidneys are the seat of high blood pressure through the what we call the renin-angiotensin aldosterone system, they have high blood pressure. So high blood pressure itself causes kidney disease because of it tears through the small blood vessels when your blood pressure is not well controlled, and that causes damage to the filtration units, and that is what is causing the loss of your filtration units. And so as you lose your filtration units, your kidneys get the function reduces over time. So now that is why we always emphasize that as you age, once your age is above 40, you'll get yourself checked. Now, it's the other way around. Hypertension appears young in younger age group in Africa. Because of some of these reasons, because one of the things that we should also understand that the kidneys of a Black person are used to conserving salt compared to the kidney of a Caucasian. And so most of our hypertension are volume dependent. And the reason why is just an adaptability of our kidneys to our environment. And so with all the other factors, you have your gene expressed in the kidney, trapping more salts and all that. So that puts you at risk. Like I said, I made that statement that hypertension is a disease of the Black people. It's not a disease of Caucasians because of all these numerous reasons. And there's a lot of studies going on now, especially which I'm part of, which is we're trying to link a gene to why people have hypertensives in Africa and among the Black kind of communities end up with chronic kidney disease compared to Caucasians.
Thank you so much. I've got many questions here, but I can see a hand up, so I'm going to default to it's the name is Mr. and Mrs. Rudd, and then it's got a number of numbers, but your hand is up. So please feel free to unmute and contribute. Oh, well, so we've got another person who's thinking if Mr. and Mrs. can't speak, I will speak. So Anita, your hand is up. Please feel free to speak.
Hi, thank you. I've got a question. Do you know when they find like traces of like protein in your urine, like during pregnancy and that, is that like cause for concern for like kidney disease?
Okay, that's a good question. Pregnancy, when you're pregnant, your kidney is going to an overdrive. So your kidneys hyperfiltrate. And so you will find some, when you find just traces of protein, and also sometimes secretions from, there's increased secretions from your front passage and all that. So those things can, but when you have significant protein, once you have significant protein in the urine, it always matches with high blood pressure, because your blood pressure begins to creep up and you have protein in the urine, then we begin to be alarmed. We are beginning to develop in the future preeclampsia. But just finding a trace of protein does not class you as having chronic kidney disease in pregnancy, because the pregnancy, the kidney goes on overdrive. We call it hyperfiltration. And so it filters because it has another features there to look after too. So does that answer your question?
Yes, thank you very much.
No
Thank
problem.
you.
Thank you. There was another question in the chat about protein in the urine and, you know, what can cause that as well. So I think you've answered some of that, but I don't know if there's anything else that you want to expand outside of pregnancy with that.
Okay, well, one of the things that if you have high blood pressure, please, when you go and see your doctor, always emphasize that they should test your urine for protein, because if your protein is above, we quantify it. Usually we quantify it. If your protein is above a certain level, I will want to change your medications to something that will protect your kidneys against the protein.
Yeah. Okay.
So that's why it is important. Hypertension is a recognized cause of protein in the urine.
Yeah. No,
diabetes is a recognized cause of protein in the urine. And so if you're, even when you have diabetes, and that's what we call early recognition of diabetic kidney disease, is when you find even little amount of protein, we're on fire. We want to get that under control so that it doesn't get into overt nephropathy. Yes.
Great. So, and I think it's, again, with the protein, and I'll come back to the antihypertensives in a second. So how do people know that there's protein in their urine? So you're so right. You've exactly said, if you've been told that you have hypertension or you've got diabetes, push your doctor to make sure they've dipped your urine.
Yes.
But are there any other symptoms that people could flag them that things may be awry?
Now, I need to be careful what I'm saying here, because people, if your urine is concentrated, your urine will be foamy, because some people don't drink enough. So if your urine is concentrated, it will be foamy. But one of the things that we tell people that foamy urine, especially when you're passing large volume, is an intent to check your protein. To protein your urine. So that's why I said I have to be careful what I say. Otherwise, people's urine is concentrated and they get foamy, they go, oh, I have kidney disease now. You know.
No, thank you for that. I think it's one of these things that it's important to be educated, but it's important to discuss what you've learned and you think you've learned with your doctors as well, so that they can make those discussions with you. So I just wanted to pick up on hypertension, just about the antihypertensive medications and any of those that could cause kidney disease. Are there any, a couple of people have flagged that up as their concern as any hypertensives that could worsen kidney disease?
Okay, I think that is quite important, because I've had people who have come to me, who have been referred by doctors to me to say that, look, it's my medication, my hypertensive medication that caused my kidney disease. It's not true. Now, most blood pressure tablets, it brings down your blood pressure and releases the pressure off your kidneys. But there are some patients who the blood supply to their kidneys is narrow for some reason. So there are some medications that you can use that can reduce that blood supply to the kidneys, to further reduce it. So some of those medications, and that's why your doctors should be able to evaluate you properly to give you the appropriate medication. So, but one of the things you should also be realized that if you're sick, there are certain blood pressure tablets. If you have maybe fever, or you have infection, chest infection or urine infection, there's what we call sick day rules, which mean that period for 3 days, you are not well, you're not eating and drinking, please don't take your blood pressure tablet. Just leave it for 1 or 2, because that time maybe your blood pressure might drop drastically and all that. So to just answer that question is that there is no documented evidence that antihypertensive directly has a toxic effect on the kidneys. There's no evidence. But having said that, like I said, there are certain patients who have certain abnormalities in their kidneys, which is their blood supply, which is the renal artery, the kidney artery to the. Let me just bear with me just for 1 second. I'll just bring up my slides again, and then just show what I'm just talking. Okay, so if you look at that's the artery. So this artery here becomes very narrow in some people. And so if you give some medications, like especially ACE inhibitors, it might compromise further the blood supply, especially when the blood supply is narrow in some people, because either they are born with it or because they have what we call blood vessel disease. Maybe their arteries are all diseased. Yeah. So that is what, in those situations, we need to be careful about certain medications we use, like ACE inhibitors for high blood pressure treatment.
Thank you. That's great. Thank you so much for that detailed answer. And one thing I would just like to say, your slide on the myths about hypertension, I wish that we could get a snippet and share it to all our friends and family on WhatsApp.
I can share it again, because that's something that is so important. I just said, yes.
I had that with my father-in-law this morning. So I was hoping that so I think it's a really good slide to share, but I must.
Yeah. We still have about 15 minutes, 10 minutes. So let me just share that slide to the audience. Look at it. I always say that busting the myth in hypertension. Hypertension is not a temporary illness that will resolve, please. It's not.
Yeah.
The absence of headaches and dizziness does not mean good hypertension control. It doesn't. There is no need to experiment with stopping treatment to see if symptoms will reoccur. Please, do not stop medication because of lack of symptoms. And do not wait for symptoms to arise before you take your medication. Now, if you want to reduce, if you feel dizzy, please go and see your doctor. They will just reduce the dose of your medication. Don't say, I'll stop it, my hypertension is cured. That's why I think my blood pressure is 120/80. So your blood pressure is 120/80 because you're taking blood pressure tablets. Now, one thing I want to emphasize that the way blood pressure graph is, your blood pressure rises sharply in the morning when you get up. And if you look at most strokes happen in the morning, early morning. Because of the sharp rise in blood pressure, the clots are moved and all that. So, but you need to make sure that if you look at your blood pressure dips most at 2 a.m. in the night when you're sleeping, between 2 and 3. And when you get up, it gets up. And so you have to take your blood pressure and all that. So, but you need, before you reduce your blood pressure tablet, you need to consult with your doctor. Now, the other thing that I want to emphasize is that we do not give aspirin as a normal treatment, as an adjunctive treatment to patients who are hypertensive, except there is a risk factor that we have identified. And these days we do what we call risk calculation of your possibility of getting coronary heart disease or getting a coronary heart disease before we put you on aspirin. Because if you look at the data, those that have high blood pressure, if they have a stroke and they're on aspirin that is not needed, their stroke is not the embolic stroke, is the hemorrhagic stroke, which is they bleed into the brain, and the outcome is worse.
Thank you so much. And Mr. and Mrs., you still have your hand up. Would you like to speak? Okay, if not, I'm going to move on to Ngozi, please.
Thank you very much, Dr. Vanessa, and thanks, Prof, for this insightful session. Just two questions, please. You had a slide about stages of chronic kidney disease. If someone had kidney tests done and they had about 57%, are they going towards that chronic level? And then the second question is, what if they're at that stage where they've got that 57%, should they obviously avoid salts and anything that's got potassium in it, like plantains and bananas? Thank you.
All right, thank you very much.
And sorry to interrupt, Prof. Ibi, the salt issue and what Ngozi's raised has come up a lot in the chat about salt and kidneys and our foods, which we love salt, and how, so if you could weave that together, that would be fantastic. Thank you.
All right, no problem. Now the question I want to ask Ngozi is that the person that has a kidney function of 57%, does the person have diabetes, high blood pressure, or any other long-standing medical problem?
Yes, the person is diabetic.
Diabetic, yeah. So the person has 57%. So what age bracket is it? Is it 40 to 50, 50 to 60, 60 to 70?
50 to 60.
50 to 60, okay. So this person has a kidney function of 57%, and we don't know whether the person has also has associated protein in the urine. Is the person seen any of their GP? Yeah, the person is seeing the GP.
Yes.
Okay. Yeah. So if you have a kidney function of 57%, we don't just take one figure. We just want to see whether that 57% is stable over years. You understand? And so basically, what happens here is that one of the things that we ask in this kind of situation is get your diabetes well controlled and blood pressure well controlled, your dietary, your salt intake, all those things to be balanced and all that. But I will not go further to say that, oh, knock off this food, knock off that food, knock off that food, because these days what we advocate is things in moderation. But I know that our people like salt. So that is something that we need to work on, especially if we have a chronic long-term illness like diabetes. I always say that a lot of people die with diabetes, not diabetes killing them, because they are doing the right things.
Thank you. And it's I think the salt aspect and the decision making of what to do is difficult for many in terms of, is it enough to just put a tiny bit of salt on, or should I be eliminating it completely? Perhaps I'm talking about personal choice, personal experience.
All right.
But,
okay. Can I jump in? Can I jump in here? Now, what I always advocate is that if you use salt to cook, don't add additional salt when you're eating it. Because what happens is that people, as of instinct, they just take salt, they just pour like that on their food and all that. And also, we must take into consideration some of those seasoning that we use are salt-based seasoning. So we should also be mindful of that. So if, for example, if we use like 5 cubes of Maggi and then we want to add more salt to it, I mean, that is going to be, if you look at the content of Maggi itself, 1 cube, and it has quite a bit of salt.
No, that's incredibly helpful, and I think comes to align with this as well. And just also, one of the questions in the chat was about alcohol, excess alcohol and kidney disease. What's your view on that, please?
Yeah, now the thing that there are the things I want to mention with alcohol now. One is alcohol does not have direct impact on the kidneys. Alcohol has direct impact on the liver. It causes liver disease. It's the commonest cause of chronic liver disease in the Western world.
Yeah.
Now, but indirectly, alcohol has effect on the kidneys by raising your blood pressure. If you take a lot of alcohol, your blood pressure rises by up to even 10 to 15 millimeters of mercury. So one of the things we talk about lifestyle changes is reducing your alcohol content in hypertension, and that indirectly can help with your kidneys. So it's not a direct causative effect. Now, on the other hand, smoking has a direct impact on the kidneys. Yeah. So one of the things that we advocate for our patients is that they should consider smoking cessation.
Yeah. Mm-hmm. No, that's incredibly helpful. I think, whether that direct and indirect is really important, because then some people will be like, no, it definitely doesn't affect my kidneys, so that's fine to continue and things like that. So no, that is really helpful.
Sorry, Vanessa, there's the people are raising their hands.
Yes, we've got, I'm trying to balance it because we've got a lot in the chat and hands up. So I haven't forgotten you all there, but actually I'll go to one of the hands up. Valretta.
Thank you, Vanessa. Thank you, Professor. My question is, are all back pain related to your kidneys, and how can you tell the difference?
Okay, right. Okay, that's a question that I get every time in my kidney clinic. First, somebody will come and say, my back, I have low back pain, and so is that the kidneys? The answer is yes and no. Now, if you got pain from the kidneys, there are three things that go through our mind. Do you have an infection, in which case you'll be very unwell? Two, do you have a kidney stone, which will be very painful, will require you to go into a hospital? Or do you have cancer of your kidneys? And so those are the three main things. And usually most people of middle age and things, and even people, depends on the kind of work you do, have low back pain in this day and age. And people sit for long on their jobs and things, and so people do less exercise. And so it is difficult to say that your low back pain is due to kidney disease. Like I said, the three main things that cause pain from the kidney are kidney stone, infection, and tumors in the kidney. And usually the patients are very sick, and there are other associated symptoms that will allow you to see that. So the answer to your question that all back pains are not due to kidney disease.
Thank you, Professor. Could I ask one more question, please? You've mentioned in a lot of the slides about dietary supplements to avoid them. Can you say which ones in particular?
And Barretta, I'll come in as well, Prof. B. That question of herbal medications and which ones are okay to take or not has come up in the chat as well. Yeah, thank you.
All right, so it's difficult. There are 1 million herbal preparations out there, I still remember, yes, I mean, the last time I did it, I gave a talk, somebody asked the same thing. I mean, that one, it was very specific to talk about nutmeg and all those seasoning, and they use, some people even now drink, have it as a morning refresher, putting nutmeg in water and mixing it and drinking to see whether that would make a difference to their well-being. But what I would say is that, there are some of the things that, in all these shops sell, they are very well regulated. The ones that I'm talking about are something that Chinese have, where people just buy them online. And I've seen people who have ended up on dialysis with that. So there are no, I can't on top of my head tell you about specific herbal medications, but there's enough, there's a lot on the internet in terms of herbal medicines and how harmful they are to the kidneys.
Thank you very much, Professor. That's very helpful.
No, great, thank you. And Dr. Tricia, who's watching as well, highlighted about, as you said, there's so many. Aloe vera latex is nephrotoxic and things like that. So there's a whole host, and it's about checking what you're taking and what the contents are and reading about it before simply taking it, as Prof. Ibi says. So that's fantastic. Chief Dr. Bob Emmanuel, thank you for your patience. Over to you.
Thank you very much. I want to first of all thank Professor Ibi for a wonderful presentation. I'm going to be taking two simple questions, simple but important questions, and then I will bust one myth. Question number one, are there cases of transient proteinuria in otherwise normal patients? Secondly, there are some people who drink their urine. Do you have news for them? And to bust the myth, you spoke about the chicken and the egg, which came first. It definitely the chicken came first because the chicken was created by the Lord God Almighty. And the chicken Thank you.
Thank you very much,
Thank you
Chief.
so much.
At least it puts a lighter mood to the discussion.
Yeah.
Right. Okay. So those are very important questions. Now, in terms of the first question, which you said whether there is a case of transient proteinuria, of course, if I give 3 people here, if I give 3 patients their urine sample and give them urine dipstick, it's observer. There's observer variation, and so I do not believe that there's any entity in. If you go to the called transient proteinuria. Sometimes we check for protein in the urine. If you tell your nurse to check today, she say no, there's no protein. The patient comes the next day, oh, there's a trace of protein and all that. What we do is we quantify the protein, and that is what gives us an idea whether this is something that we should worry about, because we take it in a context and look at the person who comes to see us. If you're diabetic and I see protein in the urine, I'll quantify it. And I want you to come back again to see whether we'll find us in protein or not. So my anticipation is that because diabetes causes kidney disease, so protein is the first sign that I will begin to alert me that whether are we dealing with early nephropathy, early kidney disease. I don't want to use medical jargon here so that people will be lost. So that is the case. So there's no entity called transient proteinuria. If I may confirm that. Now, for those that drink their urine, to be honest, if you look at the concentration of urine, if you drink urine, it's not going to kill you. It's not going to kill you. The body's adaptive mechanism, it's not going to kill you. I mean, because there are people that I've seen. I mean, I was following a documentary where a guy who was in the desert, it was very dry and very dehydrated. He drank his urine to just break his chest. So if you're drinking your urine for a medicinal meat purposes, I think that's something that you should not do, because it's not going to do anything for you. It's not going to do anything for you at all. And creatinine and urea, if you take creatinine and urea into your bowel, it's not going to kill you. It's not going to do anything to you. You just get it, because the stomach will just neutralize it. As I answered your question, Chief Dr. Babana.
Just to add, the patients who do this, they are so hooked on it that no matter how you say or how you discourage them, they just will continue. They put it in the fridge, it cools, and they have it as a refreshing drink. And if all the things in the urine will not harm them, then
it's not going to harm them. Yeah. They put it in the fridge, it's refreshing, so they just drink it. Just like they're putting some cocktail inside something and then drinking it. It's not going to harm them,
So the final thing is the urea and dehydration.
Proteinuria. I mean, even if you're dehydrated, if you don't have a kidney disease, you don't have protein in your urine. It doesn't cause proteinuria. You just have concentrated urine. That's it.
Thank you
Thank
very
you so
much.
much.
Yeah.
And thank you, Chief Doctor, for your questions and your animation. I love it. So that's great. And I love in the chat that people, someone has said, okay, so urine, a refreshing drink. That's going to be one of the reflections after that. But what I do want to say, and just to acknowledge to everyone, is that we had some technical issues earlier, and we would normally finish at 12:15, but we juggled things a bit, and we said that we would go on to 12:30, but we're completely respectful of your time, and we just want to thank you for engaging. If you need to move on to the rest of your day, thank you so much for being here, and I'll sure that you'll welcome me and join me in thanking Professor Ibi. But if you are able to stay, Prof. Ibi has kindly said to 12:30, and I know that we've got a couple more questions. So, but just want to acknowledge everyone's thanks, everyone's time today. So, Prof. Ibi, just to highlight, so some people have been sharing experiences, which I love about the health hours. So talking about seasoning and salt, and commenting that adding some garlic granules can sometimes reduce the salt content. And so thanks everyone for sharing with each other, because that's the point of today as well. So just a question on anti-epileptic drugs and its effects on kidneys. Just there's a question about that.
All right, anti-epileptic drugs. I mean, basically, I mean, its effect on the kidneys, yeah, kidney disease, yeah.
Yeah.
I mean, if you got epilepsy, you got to take your medications. Yeah. The only thing with if you have advanced chronic kidney disease, then they need to cut the dose of your drug. They reduce the dose, because some of those drugs are excreted through the kidneys. Mm-hmm. So there's no evidence that anti-epileptic drugs have a direct toxic effect on the kidneys, apart from the fact that it accumulates because the kidney cannot get rid of it, in which case you begin to get symptoms of drug toxicity of the epileptic drug, which may not be, well, one of the symptoms may not be related to the kidney. So if you have advanced kidney disease, your physician will need to reduce your medication, you know, and make sure that you get the appropriate treatment, not giving you drug that will accumulate. So the answer to that question is that you don't have a direct toxic effect on the kidneys.
Great, thank you so much. And just about stones were mentioned earlier, kidney stones as one of the causes of back pain. And just to say that we have a forthcoming health hour on the 29th of November, which talks about stones that can occur anywhere in the body. So I'm sure that will come up then. So look forward to having you there as well. So
yeah, can I just jump in there for kidney stones? Now, kidney stones. I mean, kidney stones is a disease of Western world. Because most people don't drink water here. I mean, if you look at the content of the stone, and they're you know?
I was inspired today, everyone.
so people don't drink water here. People drink cups of tea and all that. And if you look at those tea, there are granules in those teas. I mean, these things are clumped up and just cause you know, kidney stones and cause problems which you know, sometimes they cause obstruction. Majority of the time, kidney stones just remain dormant there. They may not do anything, but they can cause an obstruction in the channel. If you look at the kidney diagram that I showed you, let me just bear with me. Let me just show that you know, where the obstruction can take place. So if you look at the obstruction, it could take place here. It could take place in the inside the kidney, but most of the time, when it causes problem, it is stuck in the ureters. That's when it causes severe pain. I did mention kidney stone as one of the causes of pain around the back. It's very severe in that, I don't know, some people have described as women who have had kidney stone have almost like labor pain. That's what they've said, you know, and then you could find the stone in the bladder. So let me just fast forward and just show it to you. So the kidneys, the stones can be lodged around the calyces here before they get into the into the ureter. So that's how kidney stone track on. But the risk factors are people don't drink enough.
Thank you. And apologies, everyone. I said where stones can appear in the body on the 29th of November, but it's the 26th of November. So 26th of November, we'll be hearing more. So that's great. And another question, we've got 1 minute left. And I have to say, this has been a fantastic session. And I can see that people don't want to stop. And I hope that we've done justice to your questions. But I'm just going to end on two very quick questions. One of them is about vitamin D. Does that affect the kidneys if you take that as a supplement?
Vitamin D does not affect the kidneys as a supplement. Now, what does vitamin D do? Vitamin D essentially is an interface between, if you take vitamin D, it gets into your mouth, it gets into your gut, then it is activated in the kidneys. So basically, how do vitamin D affect, if you take too much of vitamin, if maybe take loads and loads of tablets every day, just taking it, it will raise your calcium level. And if it raises your calcium level, you can be prone to kidney stones. Mm-hmm. But the quantity that is in the supplement is so small that it's not going to make any difference. Mm-hmm. Yeah.
Great. Thank you so much. And I just want to end on someone's reflections about someone they know, because I think, again, it's bringing up hypertension again. But I think, again, so important in everything that you've said is that someone says, I know someone that has stopped their hypertensive medications because her hypertension was cured by losing weight and fixing her diet. Is that possible?
Yes. Now, just to make a comment on that, I mean, sometimes one of the things, when you say cured, I wouldn't use the word cured. I mean, you're using lifestyle modification to manage your high blood pressure. That's what I will use. I won't say cured. So if somebody is obese or overweight and you're taking just one agent, one blood pressure tablet, and so you now said, okay, I want to stop taking medications because I want to use lifestyle modification to manage my blood pressure. Mm-hmm. That is possible.
Yeah.
So you're using non-pharmacological method to control your blood pressure.
Yeah.
Yeah. So if you stop that lifestyle modification, your blood pressure will go up again and you go back to your medication. Mm-hmm. Yeah.
I think that's really important in the prevention, and it kind of ties on to a question on YouTube that says about getting to the, instead of increasing medication, what advice can you give in order to get to the root of the problem? So they say, decline in 30% function not linked to diabetes can heart-related medication be the cause? So I think it's this concept of other ways of managing it. And I think what you've just said there about prevention and lifestyle modification is powerful, but you've got to maintain it.
You've got to maintain it, because it's not when you say that, then after about a few years, you had another 1 stone or 5 kilograms, your blood pressure begins to creep up again. In which case you require medications. That's the point I'm trying to make.
Yeah, no. Prof. Ibi, I just want to say a huge thank you. I've seen so many positive remarks in the chat. Everyone's just felt it's a fantastic presentation, and you can tell the success of it with the nods, the engagement, but also the fact that no one wants to stop. And on a Saturday morning when everyone's got busy days, that's no mean feat. So we just want to thank you for your time, perseverance, and sharing your knowledge. And obviously we know that you'll be on again. You're a regular contributor to the Health Hour. So we thank you for that. And so thank you again. And I also just really want to thank everyone that's come on today, the CAFIP collaboration for convening this and getting your members and your networks to come on, and all of you that are on. Again, we never take your time lightly. We don't take your time lightly on a Saturday morning, and your engagement has made this a wonderful session. So thank you so much. And if you would like to feedback, any further questions or reflections, then the email is in the chat, health@cahn.org.uk. But again, once again, thank you all so much. And we look forward to seeing you next week. So thank you. And Prof. B, have a wonderful rest of the day.
Thank you.
Thank you all.
Thank you very much.
Thank you, Professor.
Bye all.
Thank you so much. Thank you.
Thank you, everyone.
Thanks. Have a good day.
Excellent, Vanessa. Thank you.
Thank you very much. Thank you, Prof.
Thank you.
And the organizers.
Thank you.
Amazing session.
Thank you, AB. Wonderful presentation.
Thank you.
Thank you all for the presentation.
Thank you. Thank you, Mama Marine.
We're grateful.
Amazing, amazing. Thank you so much.
Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.